I think we've learned a lot of things over the last 20 years, and interestingly, I've been in spine surgery for just over 20 years now. I went into spine mainly because there were so many unanswered questions. This was an area where we didn't have great solutions to a lot of the problems that face us. And unfortunately, there are still areas like spinal cord injury where we don't have great answers. But we've learned a tremendous amount about degenerative spinal diseases. For example, when a disc herniation, quote, needs surgery versus when it probably doesn't. So I think when to operate and how to address these problems has probably been the most important thing we've learned. But then when we do operate, we have a number of new tools that make surgery far safer. Sometimes that means doing the surgery through smaller incisions, but we have techniques from microscopes for visualization to nerve monitoring, to CAT scan, to computer guidance, all of which make spine surgery a more reliable thing to undergo today than it was 20 years ago. I think there have been a number of changes, both in terms of the kinds of things we can treat, but just as importantly, who we treat. So when we talk about disc herniations, for example, I remember in training being taught that certain discs, quote, needed surgery. We know that isn't true today. We know that at least 80% of people with a disc herniation don't need surgery. And so the most minimally invasive surgery is no surgery at all. And it's very important when being evaluated for a spine condition that appropriate non-operative treatments are considered as well. But that being said, we have better systems of retractors, better lighting, better systems of navigation that allow us to do what we need to do through smaller incisions, and most importantly, affecting the normal tissues around the spine less. Ultimately, our goal is to get people back to life and function as quickly as we can. And I think that non-operative management, when that's possible, we'll certainly do that over recovering from a surgery. But if the problem just isn't getting any better, you want to take away whatever the offending problem is, a disc pressing on a nerve, things like that. If you treat the problem less invasively, you don't move the muscles as much, for example. You don't subject the patient to as much pain or as much weakness so they can get back to their life and activities. Typically, we don't brace patients after the surgeries we do at nearly the rates we used to in the past. All these things allow us to get patients back to life. And of course, smaller incisions typically mean less blood loss and lower infection rates. Well, certainly with smaller incisions and more focused surgeries, we can get people up and walking much more quickly. Usually people are walking the same day, which may seem like a mean thing to do after you've operated on someone's back, but most of the discomfort's from working around the muscles. And so like any Charlie horse, getting people up and going is a great way to get them both over the pain of surgery, but also out of the hospital and back to their lives. With that in mind, we know that patients that used to stay for 5 to 7 days typically stay to 2 to 3 days, and a number of the procedures that used to require a hospital stay are now done outpatient. So there have been a number of changes along those lines. The truth is, the vast majority of spine problems can be successfully treated without surgery. Our practice, I think, does a great job of that because of the way the practice itself is set up. A patient can be referred to me as a spine surgeon, but typically they won't come straight in to see me unless they have one of the rare, dangerous problems. More typically, they'll see one of our non-operative specialists first, and they'll be given plenty of opportunity to improve with non-operative care. And if they're making good progress, they may never need to see the surgeon. On the other hand, if the problem is having a significant disrupting effect on their quality of life, or they just aren't getting better, we can move them straight over to operative management and get the problem addressed. And for disc herniations, for example, we know that the vast majority will get better. The ones that do get better, though, typically do so in the first 6 weeks. So rarely should someone have surgery within 6 weeks. On the other hand, as we look at large groups of people that have had disc problems, if you wait longer than 6 months, the results start to get a bit worse. That doesn't mean someone necessarily has to rush into surgery at that point, but it does give us a window that's sort of the optimal time to consider surgery for a very common problem.